So good morning, everyone, and welcome to our workshop, Mission-Driven Health Ecosystems. Our session aims to discuss how regional innovation ecosystems can improve citizens' health and well-being, and how different innovation players can collaborate. My name is Moises, and I represent Cyric Yumbik and Gravity Incubator in Cyprus. Our session has been inspired by the work at EBN and EBN members are carrying out in the framework of Cherish project, which aims at testing responsible research and innovation and demand-driven approaches to inform and shape regional smart specialization innovation strategies in the healthcare sector. Before proceeding and giving the floor to our guests, I will briefly introduce our activities and role as Cyric Yumbik. So we are the EBN member here in Cyprus, and given the catchment area, our activities and role are national. They have a national impact. We have been supporting innovative startups and SMEs from idea level all the way to market readiness. And as an Yumbik member, we maintain the role of the mediator between research and innovation practices to concrete business action. I will be moderating this very interesting session for the next 40 minutes. And I will kindly ask for our guest speakers, which are Mrs. Lydia Montandon, Mrs. Magda Krakowiak, and Mr. John Rigby, to start by introducing themselves. Given the fact that the Congress should take place physically in Brussels, let's start from Magda.
Hello, good morning. My name is Magda Krakowiak. Thank you for having me. I work for EIT Health, which is a knowledge and innovation community that is responsible for sorry, I have a overlap with the voice. If somebody from the technical end can help us. Yes, thank you so much. Apologies. Once again, my name is Magda Krakowiak. I'm head of open innovation at EIT Health.
Magda, I can hear you clearly. Okay, let's proceed with Lydia until we fix the issue with Magda. No worries.
Okay, hello, good morning. Thank you for inviting me. I work at Atos. It's a global digital service company. I work within the research and innovation team, dealing with innovation management and also searching ways to bring the results of the research and innovation to the market. I'm also a member of the EIT Health Supervisory Board, and this is where I connect with Magda. She will later come in with her role. I'm interested in responsible innovation, not only because being a member of the Atos scientific community, I may have the opportunity to influence and raise awareness in the company about the importance of responsible innovation, but also to put forward the idea how to bring it into practice, thanks to the knowledge gained by participating in a European project, the Living project, Living Innovation, where we try to study how responsible innovation activities, like involving society in the co-design of solutions, can be embedded in the innovation process.
Thank you, Lydia. John?
Well, good morning, everybody. Very pleased to meet you in this sense, a strange sense, but nevertheless, very pleased to be here and to be able to just introduce myself and talk about these important issues. I'm John Rigby. I am an honorary senior research fellow with the University of Manchester, and I also have my own consultancy and innovation consultancy called Biometrica. That's been going for a little while this year, and I've previously been working on procurement of innovation, and in particular on pre-commercial procurement, which of course is very much a kind of a keystone for the support of innovation in a whole variety of areas, and increasingly in health. I've worked on the early days of pre-commercial procurement and supported DG Industry in the development of its approaches, and also with supporting some of the work that was done with DG Research that has led to the PCP activities and the SME instrument. I've been working on health just more recently, and looking at regional innovation and at innovation intermediaries in the Manchester area, one of which, Health Innovation Manchester, is very central in our own regional picture. So very much looking forward to talking a little bit about this and hearing what others have got to say. Thank you.
Thank you, John, and it's very nice having you today with us. Magda, can we go back to Magda?
Yes, apologies for the technical hiccup. Yes, once again, my name is Magda Krakowiak. I'm head of open innovation at EIT Health, which is a knowledge innovation community established by the EU to tackle the challenges of health and demographic change in Europe. We are a partnership of over 150 partners across the whole Europe, ranging from industry, academia, and research, but also healthcare providers, payers, and regions. So we basically encompass all the important stakeholders in the healthcare sector. Thank you.
Thank you, Magda. When I was first proposed to join this panel discussion as a moderator and I saw your profiles, I was very happy because as in Cyprus, as an EBN member, we have a leading and national role on the local ecosystem here, and health is one of our new challenges, also coming from our in-house expertise, but also our role as an innovation catalyst, let's say, locally. So recently we have been going through the transformation of the general health system. So everything tries to integrate through this ecosystem, and apparently innovation and demand-driven approaches are very vital components of this recipe, let's say. So one important question is, how are innovation approaches in the healthcare system changing? And do you have any concrete business examples to use on that? Magda?
Yes, thank you. I think it's we are living in a really exciting times when it comes to innovation in healthcare. We've been through stages where things had to be better, right? So we had things. Our healthcare system became very expensive because we had things that were better but were very expensive. So basically, making things better was not good enough anymore, and then we moved toward making things better but also more efficient and cheaper, right? So delivering the value for money. Then another, let's say, shift that we see is from technology-driven innovation. So we have this cool technology, and people tend to fall in love with those all the opportunities, right? That the technological advancement brings. That now we see that moves more towards the needs-driven innovation. So it's not only what is what is cool or what potentially can be solved, but mainly what has to be solved. What are the needs? What are the real needs out there? And another trend that we are very excited about is that there was a lot of conversations in the past about the process and performance innovation. Let's say we've been measuring a lot of those things, and what you measure, you actually can see, right? You cannot see what you do not measure at all. To the shift that we observe now is more towards outcomes and value that is being delivered through healthcare. So this is a very exciting time where, first of all, we have in terms of technology, there is potential. We've started capturing a lot of data. I think that I've seen a recent study where it says that healthcare is one of the sectors where we gather the most data, but we underutilize this data at the moment. And the last thing is let's say the culture shift that needs to happen. That we bring, let's say, that we concentrate on the value and we make the healthcare innovation more inclusive for the patients and for the citizens, right?
Taking that, I would highlight from you that we're talking about the high value care that is need-based, and
exactly.
Need-based high value care means that the provider is able to identify the need, but also the one that is receiving the high value care also is able to identify and know the need. Lydia, do you have anything to comment on that?
Yes,
the interaction.
So effectively, you mentioned this high value-based care, and which is for us in Atos, this means that it's patient or customer satisfaction or experience oriented. It's the key driver. So for this, we think that the solution is to empower citizens or patients, help them deal themselves with their own health, be able to choose the kind of treatment they will adhere to, or choose even between an operation or treatment. If this is possible, of course, they should be informed. They should be the owners of their own health record and not the hospital or the healthcare system. So we consider a framework where citizens are able to make their own decision. It's true that for this we need to educate them, educate the citizens, the patients, of course, also provide enough information to them and that is clear and understandable, but also to the health professionals, because in the end they are the one who faces the patients and they have to have a different approach, and also the healthcare systems, because we need to educate in somehow the decision makers in this sense. So there is behind this also a shift towards prevention or behavior change, healthy living, diet, mental health, and so on. And in this sense, there is a lot to do. It is also easier to develop responsible innovation because you can engage more the stakeholders in the co-design and the phases of the technology development. And in my experience, it's very interesting to listen to young generations. They appear to face a lot of stress and they don't think of their future health. They are not preventing anything yet, but still they are looking for solutions that today can prevent bad behavior. So I think this impacts the way we design healthcare systems with more focus on citizens and prevention, education, patient-centric, and not from the perspective of the healthcare system.
Thank you very much, Livia. And indeed, education and preventing approach is a way forward, as it seems. Also, through our co-creation process with Cherries, we see that involving all these multiple stakeholders, which they are moving on different, let's say, approaches and speed, we need somehow to find some common ground. And what you're suggesting seems to be very ideal, let's say, to base our need-based identification processes. John, from your academia background, and you are also your role as a board member of Cherries project, what is your observation on the innovation approach?
Well, thank you, Moises. I think that Cherries is trying to make integration and particularly integration of patients very, very important in innovation of new treatment. But I think from my point of view, I see the kind of integrated model of healthcare becoming increasingly important, and it's been a kind of an approach that's been widely practiced and implemented in a whole variety of cases. And the UK is going down this route. Other people have been trying it for a long time. I think that Obamacare to some degree takes this approach, population-based approaches, which are in a sense more efficient in the broader sense, and where everybody is involved and plays a part. And it is in a way an attempt to kind of create an overall system. Previously, I suppose we can say that maybe innovation in health has been, I won't call it piecemeal, but because there has been some recognition of a system, but there is now genuinely an attempt, I think, through population-based approaches to make it more connected and to get everybody to play a part. But I think this means that we're all being asked to do more. We're all being asked to think about what we do and what bits of the system, how they connect. And I think that's a real challenge for innovation. Well, everybody involved, including innovation intermediaries, because integration can happen at a whole variety of levels right across the piece. So and obviously digitalization, which we've begun to talk about in this session, is very much an underpinning technology, because that connects the different parts together.
Thank you, John. That gives me a good step forward, because we keep on talking about the system, and the system is comprised, let's say, of multiple entities, and then we mentioned data, and then we mentioned preventive medicine, and then education. So that system, that very complicated system, is it flexible enough to support this shift? Where did you identify some limitations, and how would you suggest there is place for improvement? Lydia.
Yes, so as you mentioned, data is a catalyst for transformation. It's really so important. We cannot do without it. So, but of course, we face several difficulties. Of course, it allows to predict and prevent, but data is difficult to obtain. It's not always reliable. It's not always non-biased. And in general, it's kept within hospital facilities. It's difficult to take it out. It's difficult to aggregate and really benefit from a large quantity of valuable information. In this sense, the GDPR, although a very important regulation that protects us, is somehow also an obstacle to access data. So we need to find roundabouts. Another obstacle is the lack of interoperability, as the data stays within the hospital's organization, sometimes within closed and siloed organizations and systems, even sometimes in departments. We need to dedicate a lot of effort to combine multiple sources of information, which is crucial to get relevant and reliable results to make decisions. And finally, I will mention that at least in Spain, procurement processes are not helping much. It remains favoring, legacy systems that are already in place in hospitals. So in particular, we think that from the point of view of technological development and consulting, a modification of those processes that takes into account in the journey of the doctor the technology that impacts. For example, let's think to nowadays with the COVID, doctors had to take remote consultations, and this is not designed within their process. So it should not be technology as an add-on, but already in their daily lives and routines, so that it is not disturbing.
So it's amazing that, okay, we are talking about in the same paragraph with keywords such as data, and then we say legacy systems. So it gives the impression, and it's actually the truth, that it's like the old way and the new way coexisting together, being in a transition phase. And data is a major, it's a catalyst, let's say, based on what you're saying, in order to tackle these issues and to solve the flexibility issue. I don't know, Magda, if you have something to add on.
Yes, I mean, I totally agree, but then I will honk on this high value care again, because it seems like it's a concept that that seems to gather a lot of let's say enthusiasts across the board, right? So it is true that the healthcare system is full of stakeholders that have very different incentives or very different interests that they need to cover, right? If you look at the patient, if you look at the clinician, if you look at the payer, for example. But in the end, I think that this is a concept delivering care of high value where it's necessary to the people who really want it and who really need it, is an objective, or it could be a common denominator for all of those stakeholders to come together, right? I mean, industry wants to produce solutions that will be adopted in the hospitals and that will be serving the benefit of the patients. And patients, they also want to receive treatment that will be efficient and is necessary, right, for them. At the moment, healthcare, I think, because of those multiple stakeholders, is suffering precisely from what Lydia tackled. I mean, the system of rewarding and the system of incentives that different stakeholders have within the system is causing all of those problems. And I think it was a study from 2017 by OECD where we saw that at least 20%, but there are studies that say that it can be more, at least 20% of resources are actually misused. So they produce treatment that is either harmful, which should never should never happen in healthcare, or is unnecessary. So somebody is getting a type of a treatment because it's within the, I don't know, healthcare pathway, and maybe it's not the necessary thing. So it's misuse of resources, and we know how the resources are very scarce in healthcare. Healthcare is more and more expensive. Our population is aging. So those are pressures that we will be feeling more and more here. So we should really concentrate our efforts on channeling those limited resources to the right places.
I would like to expand a little bit more on that, because we have let's say, in 3 phases: the data collection, the data manipulation, and then we have the data interpretation and the usage. So we have 3 different processes here, and each one of them has its complexity. And inevitably, for example, COVID encouraged data sharing, and we saw many barriers of sharing information, and especially, I mean, even regional. John, what's your example of the challenges and the COVID encouragement of data sharing through this era of the era of data, let's say?
Well, thank you, Moises. There is definitely an issue here, and we've got an example from the UK of where COVID has had a kind of an effect, which has been to persuade organisations, health organisations, to, if you like, come to an agreement about data sharing, and that's always a good thing, I think, to do, but it raises many questions. So we have a confidentiality and patient information regulation, if you like, in the UK, which has been relaxed at the beginning of the year, really, in light of COVID, and that has allowed, if you like, information to be shared. And in our own region, in the northwest of England, in the Greater Manchester area, then we have got the start of this process of sharing information between patient data between hospitals, general practitioners, and other parts of the health service. So that's very good. It raises, of course, issues about whether this will really stay in the long term, whether we'll really have that. It raises issues of consent. I think also when we move towards treatment that is as a result of this, and we have redesign of the system, people just won't want these kinds of innovations if they just think it's going to make it cheaper. I think that's an important point. I mean, it's got to flow through, if we're thinking of this as a system, it's got to flow through diagnosis, monitoring, analysis, through to lifestyle changes. It really has to be a completely systematic approach, and there's great potential there. Again, I talked about permission and consent. I think another issue which we shouldn't be bounced into this, although in a way we've moved quickly in this direction, is liability. When we change a system, where is liability in a system? When we start to use an app to change people's way of doing things, who's really taking responsibility there? And I think that is a challenge for what we're talking about. So we can get support for change, but we we can involve patients as is being done in Cherries. But then are we actually dealing with the issue of liability? Thank you, Moises. I hope that's a reasonable answer, and I hope nobody's hearing the burglar alarm, which is sounding very loudly near my house, which unfortunately is completely beyond my control. Burglars presumably at large.
Thank you, John. I'm still wondering though, I mean, before the COVID situation, I had double thoughts on sharing my location on a mobile app for any reason. And then COVID came in, and it was a catalyst, let's say, in this process of me being more accepting on sharing my location. And I'm still wondering, are we heading towards this direction of being more sensitive on allowing of sharing our data, feeling more comfortable for our own protection. But will this end after the COVID situation ends or another pandemic ends, or this is here to stay and, let's say, make us less reluctant and more comfortable on sharing our data? Do you have any personal experiences, even on, I mean, we're doing this online because of this situation. So do you have any personal experiences of your data shared because of this, and how did you see it as part of the process of the flexibility of the system to adopt this as a solution? Magda, I remember once you mentioned to me about your application and your geolocation.
Yes, yes, I think there is, I mean, Belgium, I'm located in Brussels, and Belgium, like many countries, launched an app, right, to tackle the COVID kind of a tracking. But the problem that I find with those type of solutions and kind of handing over a lot of responsibility into individual person's hands is that humans are basically prone to error. And then you are very right, John, that that basically the question of liability is very, very valid here. I mean, who in the end will be responsible, right? If I do not notify, there is a request from the app. Of course, it's tracking my geolocation or my Bluetooth connections between the devices that I'm surrounded with. But then it relies on my action to actually input the data if I have been tested positive for COVID. So I do not. At first, I was like, "Oh my God, this is so nice, this is so great." But then when I saw this, well, I said, "How can I trust this, right?" And then maybe people are becoming too relaxed because we have this solution at all, and they are neglecting, let's say, other measures, right? Because I see my app is telling me I had no exposure, right? How do you actually know it? You don't.
Taking on that, and on the second poll question from the audience, question is, what do you consider to be the main challenges in the implementation of a more responsible healthcare ecosystem? However, 38% answered data protection and privacy regulations, and another 38% answered procurement rules and regulations, whereas 23% answered rigid actors and 0% others. So that means that the problem is very well defined, because others is 0%. We know exactly what are the main challenges, and 38% of them are procurement rules. I'm sure that John and Lydia could expand a bit on the procurement rules and regulations based on their experience as a main challenge in the implementation of a more responsible healthcare ecosystem. Lydia?
I've gone first, but I'm very happy for Lydia to go next. If she wants to go, please indicate, Lydia, or I will. I mean, I think that we've had a tendency to think of innovation as if you like, I won't even call it piecemeal, but it is not taking place always within a system, and the risk is that we, our mindsets and maybe our procurement approaches, not necessarily the regulations, but certainly the approaches, focus on very specific, narrow, if you like, formula or algorithms for assessing the cost effectiveness of an innovation. So individual procurers and procurement departments in hospitals or in any kind of procuring organization with the health sector will very possibly have a kind of rather a narrow formula for working out where the benefits are, and really those kinds of algorithms need to be rethought. I think I really think that we're really asking ourselves to do an awful lot more in procurement suddenly, in a way, with this kind of integration idea, which, as I said earlier, is the result of partly the arrival of IT and big data, the ability to connect different processes, and obviously the pressure that we have to save money in a sector which as we know from the issues of COVID, is quite capable of gobbling up an enormous amount of money. But it will serve us very well to get it right, because I think we do need to move to a new, I'd call it a new health paradigm.
Thank you, John.
Okay, on my side, what I see with the procurement is that, at least, again, I speak for Spain, but it's a very long process. So as when they have the procurement or the tender out, it's like 3 years after they started thinking about it. So it's too late to make any change, and we have to go back again to the initial stages. And many times also the procurement focus on, well, we need to adapt our technology, so give us technology, but they don't procure what is more important, is the consulting before the technology. What you have to change, how people have to start working in a different way before you put in a technology that will not be used or be used partially because people are not aware of what it can do and how it should be used.
If I can add, Moses, to that, I mean, in my previous life, I have been a procurement lawyer, and I'm actually I know this is not the most let's say popular let's say the dream profession of people who are going to study law, but I actually fell in love with the procurement and in the power where really a big chunk of GDP of every country is being spent through the procurement, and I think that public procurement is hugely underestimated. So I still sometimes go back and I read about the procurement of innovation, because now this kind of combines my past life and my current life. And I find it extremely interesting, but I think that we need some more flexibility on the procurement side to make the law kind of reflect the reality, right? Unfortunately, this is usually how it follows. That, I mean, first technologies expand or things happen within the society, and then is the regulation that follows and tries to kind of codify, right, the status quo. It is, especially with technologies and innovations, it is very difficult for the regulation to become, to go in front of this of those challenges, right? So I think that we've seen many good examples already in Europe in terms of procurement, like pre-procurement and the procurement of innovations. But I think that it's still a long way until it will take us to those small procurement departments in a small healthcare settings, where we will be able to see, okay, this is how it should be working, right? But it should not stop us from making an effort.
Thank you, Magda. And I'm very curious to receive the answers on the last poll. What are the main challenges during the transition phase? But taking from the previous one, which 76% consider the erosion of the regulations and 23% the rigid actors, that would lead me to a third question, which is the intermediaries and the roles to achieve. I mean, how do we involve in our ecosystems intermediaries, and how do we collaborate with them in having a better and more responsible healthcare ecosystem? From our experience as an EBN member, working in different projects that promote co-creation and potential solutions, we understand first that, okay, identifying the need is very important, because we need to build something that is demand driven. However, while creating the solution and trying to sustain the solution, it's always a hurdle, let's say, to provide further support to the solution and sustain the solution even after the completion of a project, of an initiative. So, John, from your experience, so many years as a consultant, the intermediaries and their role in the UK, how do you engage them? I mean, it's very difficult to give them incentives, and at which extent. How do you keep their attention of being involved in this process?
Well, yes, that's quite a difficult question. I think. I mean,
I'm sorry.
Yeah.
I'm very interested to hear your feedback.
I don't know whether this answer is going to pass the test somehow. I mean, in our own system, we are, we're highly, well, we're regulated. All health systems are. And then it depends on what level up and down your system, where who's making the decision and who's controlling whom, and who sets the rules. And in our own system, a lot of things are because it's a national system. There is a great deal of direction from right at the top. And so I think that's where you want to see things happening, if you like. That's where you want to see incentives being put in. But then it does actually have to work all the way through to the people who are going to use the new technology, the new parts of the system. They're going to have to accept it. Obviously, we're now moving to some degree towards a decentralized system. Slightly, it's going in that direction. It may go further. Who knows? Life is not very certain. And when that happens, then new people at different levels are going to become, if you like, they're going to have the responsibility to make procurement decisions. They will need to refer up, and so again, back to the system. If it's a good idea in Manchester, should we be encouraging people in, for example, London to use it? And this is where I think national governments, which very often have responsibility, or even regional governments have responsibility. I think people have a responsibility to share what is good. So we're kind of we're always in this balance between coming up with good ideas in one particular place and then needing to allow them to go elsewhere, to be disseminated. So I think your system, if in a way, has to cope with that, and for that you need incentives. That's not a very good answer, I suspect, but it was an answer.
No, I'm very happy with your answer, John, because I can highlight towards liability, which has been also mentioned from question number 2, and the incentives. And we have the answer to the poll question, which was, what are the main challenges during the transition phase? And 62% of the audience says that regulations are not ready yet, whilst 23% say that regional policies are not responsible enough. So again, coming from question number 2 to question number 3, we see that we have a regulation issue with 2 systems coexisting together at the moment. So it's definitely a transition phase. And related to question number 3, the key word is liability and responsibility. Who is taking? I guess nobody wants to have liabilities or responsibilities. Lydia, from your experience, we have 2 minutes, let's say, to finalize this question. And I would like your input and Magda's on the liability and responsibility.
So it's true. From my point of view, there is something when, for example, a doctor relies on a tool or a treatment that is provided an algorithm, let's say, that help him take decision for diagnosis or treatment. Then there is this issue of liability. So, well, usually it's the doctor that is liable, but we need. There is an opportunity there to make the innovation responsible. If the technology is sufficiently transparent, if we can organize that it is transparent and understandable to the doctor, he can know or she can know where the data come from, how it is combined, how the algorithm is working, then the doctor can make sure it's surer that what he takes as a decision is really his own and not only something that comes from somewhere he doesn't know. So that's a little bit the idea behind.
Exactly. Thank you, Lydia. Magda.
I would take it, let's say, the question of intermediaries from a little bit different angle, looking at, let's say, all the people in the middle, like the bigs or like EIT Health, as a cluster that is kind of putting together different stakeholders. I think that anywhere, if we want to do anything in life, we need one person, a concrete person that will become an ambassador and will take the ownership and take the idea forward. But this person, when it comes to combining the two different worlds of innovation, technology, or public procurement and innovation or other places, you always need to have people who understand both sides, or however many sides there is, who can facilitate the dialogue, because we are not going to, let's say, force the clinician to use the solution if he doesn't trust the technology. So we need a person who can speak technical language, but also know how to direct, let's say, how to build arguments for the clinician to stay open up for this and change their practice. So I would bring it down that we need ambassadors to carry this work forward.
Thank you very much, Magda. And I would like to remind everyone that we have 3 minutes left in this session. So first, I would ask for a closing remark for each one of our guest speakers on how do they see the future of mission-driven health ecosystems in the framework of our today's discussion. The future, is it bright or not? And let's start this time from John.
Thank you, Moises, for again another difficult question. I sort of think of I just think, as I said before, maybe I think we're being asked to do a lot. I think that we're being asked to radically change the whole way in which the health system works, and it's a challenge to see whether we can actually make it a system, truly a system, and I'm not sure that's so easy. I think I'm just thinking about the World Health Organization's kind of thoughts about, indeed type topologies of integration, organizational, functional integration, service integration, clinical integration. These are all, if you like, the levels at which the health service is being integrated. And all of these things are at different levels. They've got to connect internally and then with each other. So there's lots of work for us to do, and lots of opportunity.
Thank you very much, John. And we can all see that you're made for the difficult questions because you provide very solid answers. Lydia.
Okay. I think that there is a strong benefit in involving society and all stakeholders in the co-design of solutions of the system in itself, and to ensure that it is acceptable, responsible, and that it will be adopted. But we still need to find an economic way to engage people in the process.
And Magda?
Yes, and from my side, I mean, I think you are asking the future is bright. I think that definitely the future is bright. For 20 years now, we see change first in theory, in academic theory, then in policy. But now I think that we finally see adoption on this citizen-patient engagement in the innovation process. So for me, this will be, let's keep on working.
The future is bright for me as well. So thank you all very much for for joining us today. It was really a pleasure. Please remember to follow the link in the chat for the networking and meet the speaker session. It was an amazing experience also to bring all this expertise and experience together, even for 40 minutes. It was a very constructive discussion. And I would like to thank you again very much for your time and your valuable input, and hopefully we can keep the conversation going in the future. Thank you very much.